Alzheimer's and dementia in general when we're thinking about what are the pathologies that create dementia, how do we prevent them? Then we'll really go through the preventable risk factors for dementia as described in the Lancet 2024 article and the Pointer study, all pretty recent papers. So I put this slide together for the neurologists that I talked to about a month ago, and I thought, why not just put this in here? You've all seen this, of course. I'm stealing this from you all. This is sorry, I'm trying to manage my screen here, which is always a dangerous thing to do. Um, uh, the cognitive impairment framework from a geriatrician. The 5 M's, of course. So some 4, some 5, but I think we're to 5 M's now. So all of these 5 M's really kind of come into dementia care. So of course, medications that people are on that could either cause memory loss or prevent memory loss. Mobility, once you start getting dementia, you could have difficulty walking, what matters most. Of course, I talked to a lady on the bus yesterday on the shuttle, and she asked me what I do. And she's like, I'm afraid of dementia. Like, this matters to people. People are really worried about dementia, not just our patients, but just like the community. Multi-complexity, of course. And of course, mind. Mind is one of the 5 M's. So dementia being part of the mind. So when I teach the fellows, if you see someone with cognitive impairment, so they have, they didn't used to have cognitive impairment, now they do. It's a true geriatric syndrome. Not all cognitive impairment is dementia. So you really need to get into how long has it been going on? Is it actually dementia? It could be delirium. It could be depression. It could be a side effect of medication. So, and I said this to the neurologist. I put a gasp in here, but I took it out for you guys. Diabetes, heart failure, renal disease can cause our brain to have some dysfunction. And then dementias are often mixed. One study suggests that less than 30% of dementia is pure Alzheimer's in a community-based cohort. That's a big deal, right? So that means that 70% of people with a diagnosis of Alzheimer's disease have more than just that. So you can have dementia, you can have mixed dementia, and you can also have dementia plus delirium or dementia plus depression. So all of this gets bundled together as kind of messy. Okay, why are my slides not advancing? Okie dokie. Sorry about this. My Zoom, PowerPoint situation has been acting up ever since I did something. Hold on one second here. Okay, I can't see any of you or my face, so I am sorry. I'm just only seeing my slides. So if a big spider landed on me, I won't know. It's probably for the best. Okay, more about mixed dementia. So an NIA autopsy study, 94% of people that were diagnosed with Alzheimer's disease. So they had Alzheimer's disease in life. They came to autopsy. 54% of them had coexisting pathology. What were those coexisting pathologies? Number 1 was vascular. Number 2 is Lewy body. A Mayo Clinic brain bank study found also that most Alzheimer's disease cases had a coexisting pathology. Comorbidity increased with age. So if you have a younger person, you could certainly see pure onset Alzheimer's, especially if you're dealing with the Diane cohort, like the dominantly inherited Alzheimer's network, someone getting it in their 40s or 50s. But you're talking about late onset Alzheimer's, we're really talking about mixed dementia, vascular, small vessel, and CAA. Lewy body inclusions. And then there's this new disease. It's not new, but we're newly describing and learning about it called LATE. It's limbic associated TDP-43 encephalopathy. And if you think that's a mouthful for you, that's a really big mouthful for your patient. And then you're like, you have LATE. And they're like, LATE for what? It's just like exhausting to try to tell them. What I tell them is LATE is an Alzheimer's mimic. I think I have a slide about it later. No, I don't. So LATE is an Alzheimer's mimic. It's not as progressive or as severe as Alzheimer's, and it tends to occur in older people. But I tell people it's similar to Alzheimer's. If you want to tell people I have Alzheimer's, I think that's okay. To your hairdresser, until we have a good understanding of this in the common parlance. So, the scope of the problem, dementia worldwide, 57 million in 2019, 153 million estimated by 2050. And when we're talking about dementia prevention, I kind of think on there's sort of two sides to this issue. On the one hand, mixed dementia complicates everything, right? It complicates research in this area. Will an intervention that prevents pure Alzheimer's work for vascular or Lewy body? It's hard to say. On the other hand, lots of low-hanging fruit. If we allow for kind of what I think is a messy pathology or a more inclusive group for a dementia prevention cohort, even though it's a little messier, we might have more to do, and real-world interventions may have more. They have more to do, and they may, if you make a cohort that looks more like the real world, it may be more effective, but you might have to enroll more people. Okay, I was asked by a couple of people to talk about plasma biomarkers. So this might feel a little bit off just because it's not necessarily dementia prevention, but it sort of relates because people who want to prevent Alzheimer's might go and get these measured. So there's a lot in the news about plasma biomarkers. I'm just going to give you Harborview's take. So the Alzheimer's, so there's a few different biomarkers out there. There's amyloid, there's ratios, there's p-tau, there's a bunch of other ones, but those are the big ones. The Alzheimer's Association expert consensus and guidance from the American Academy of Family Practice strongly recommends against blood-based biomarker testing in patients without objectives, cognitive impairment. So if someone's worried well or has like a very, very mild memory loss, like I forgot where my keys were, but I'm still working, that is not appropriate to get plasma biomarkers, period. Now, if they got them and they're weakly positive, yeah, I know now you have a thing to do about it, but they shouldn't have gotten them in the first place. They're not approved for asymptomatic people, and they're not approved for those with moderate to advanced stage dementia. What they're really for is they're for abnormal cognitive assessments, patients for whom other causes of cognitive impairment have been ruled out, and for patients who may be candidates for disease modifying or other Alzheimer's specific treatments. They're really for your people who are like, this looks like Alzheimer's, but they have a little bit, they maybe have PTSD or some other things. It's hard to say for sure if they have neurodegeneration, and if their plasma biomarker's negative, it wasn't Alzheimer's. If positive, it is. So if Alzheimer's is kind of on that differential and they have a cognitive impairment syndrome that could be Alzheimer's, then these are appropriate. There's a great Project Echo talk on this from Dr. Sussman, and this is the link for that. This is a slide from Dr. Rosenblum. We are using plasma biomarkers in our clinic to confirm people with Alzheimer's if they want anti-amyloid therapy. Those are really the only people we're sending this for. It is clinically equivalent to the FDA-approved CSF test for A beta. So just to back up a little bit, this is strange. Plasma p-tau 217 really strongly correlates to A beta status, which it's not their same biomarker, but they correlate. They correlate very strongly. They also correlate with tau, which makes sense. The advantages to plasma p-tau is it's easier to get than CSF or amyloid PET. And then we're already the specialty clinic, so you're already in our clinic. But if primary care doctors did start ordering this, you wouldn't have to wait for a specialty clinic. But that's kind of a misnomer because the only reason you're ordering this is to get it into the specialty clinic to get lecanemab. So that's kind of whatever. I think the disadvantage of the plasma biomarkers are, let's say you test positive, but you're asymptomatic. Well, now they're freaking out that they have Alzheimer's when they don't. Then what do you do with those people? And I guess this whole talk is kind of designed to, the worried well that happens to have amyloid. You can talk to them about all the things I'm going to talk to you about. If they test negative, but they have a lot of cognitive symptoms, but one primary care doctor somewhere didn't do a full history. Let's say they have Lewy body or late or FTD. Then their symptoms are discounted. Oh, you don't have Alzheimer's, you're fine. Well, actually, no, they're not fine. So you have to make sure you're ordering it in the appropriate patient. And then I don't particularly like it because you really don't see the pattern of amyloid in the brain. We just did two cases yesterday at lecanemab board where their plasma biomarkers did not jive with what their brain was showing. You know, the amyloid pattern in their brain, if it's sparing the cortex and it's in here and not there, I don't know. I'm just old fashioned. I like to see the brain. I think just overall, the big picture of these tests is one, this is just one of those tests that has to be treated with special care, like a cancer test. It's not a sodium level where you can just order it and go on vacation and you don't need anyone to follow up. It needs special care, and whoever is ordering it needs to own it. You might not need to know all the things to do after, but you need to know how to counsel them and have an appropriate plan for follow-up. And that appropriate plan may be to refer to memory brain, but having those conversations is important. But ultimately, bottom line, don't order it in asymptomatic individuals and don't order it in moderate to late stage AD. But you can order p-tau 217 in Harborview if you really want to. Okay, let's get into what we came to talk about, which is prevention. All right, we have a 70-year-old patient. You have a 70-year-old patient well known to you who just bought a supplement they saw on TV that is supposed to promote brain health. So they get it out of their bag and put it on your desk and they say, what do you think? Should I take it? I don't want to get dementia. So you pull up the bottle and you start reading it, and it's called Modify Memory. And you think, well, that's actually pretty great. And on the bottle, it states you can affect a creature's memory within 30 feet as long as the memory was something it experienced within the last 24 hours and it lasted no more than 10 minutes. And then there's this little asterisk. Like, what is that? So you go to the asterisk. These statements have not been approved by the FDA because this is actually a spell in Dungeons and Dragons 5th edition. So like this has happened to all of you, right? I mean, maybe not the D&D part, but like everybody brings in these supplements and it's like, no, like they haven't been approved by the FDA. They're not going to do the things. But you can tell them, you can harness that energy, say, there is a study for just plain old multivitamins. And so we'll go through that study. So this was the Cosmos Mind study. So the Cosmos study is a big study and it assessed effect of multivitamin mineral. I think it was just Centrum Silver plus or minus cocoa extracts. I think Nestle provided it. So there's 4 arms, multivitamin, placebo, cocoa plus placebo. And they were looking at cardiovascular outcomes and cancer outcomes. And then there was a sub-study looking at cognition. And the multivitamin group had a statistically significant benefit on global cognition. And they also had less decline in memory and executive function, which makes sense. It's what was driving the global cognition. Cocoa extract sadly had no effect. So here's that graph. So here's the cocoa extract, like maybe there was a little non-significant trend here in the blue active group, but the multivitamin mineral group over 2 years did seem to have an effect. Updated results. So they looked at people who, 533 patients who actually underwent detailed neuropsych assessments at baseline in 2 years. And they did find a modest benefit of multivitamin compared with placebo. More favorable change in episodic memory, but no change in executive function or attention. So biological plausibility. The combo of vitamins and minerals interact with multiple biologic pathways that support cognitive health. A nutritional and micronutrient deficiency in older adults may elevate risk of cognitive decline. So there's been other similar studies to Cosmos Mind. So people looking at these big supplements that they pack them full of things. So the Lipidi diet trial looked at this multi-nutrient intervention, Fortisyn Connect, aka Suvanade. It has a little bit more things to it than a multivitamin. Here's all the ingredients you can see here. Results from a 2023 study, outcome measures showed a statistically significant effect for the intervention, significantly less clinical decline over 36 months. It is now available in the US, but it is quite expensive. It's like a liquid that you drink. And here's the graphs there here. So active is red and control is blue. So you can see some Mean change from baseline of MMSE. This is ADCS, the testing. CDR sum of boxes. Now the scale are very small, so tiny little effect sizes. And these are in older, what did I say? People in prodromal AD. So Cosmos was in healthy older adults. This is in people with MCI, basically. So you can say, oh, so to your patient that brought in the D&D spell, that was a supplement, thanks for letting me know all the supplements you are taking. It's important for me to know what you're taking because they can sometimes interact with your other medications. On my research on modified memory, sorry, my light likes to turn off on me, doesn't have as much data out there. But there are data for combinations of supplements. Even just a Centrum Silver has some data. So make sure you're on a multivitamin. If you do start taking modified memory, hey, that's okay. I don't think it's going to hurt you. Check in to see how things go. But while we're on the subject, I hear you're worried about your memory. Let's talk about what more we can do. So kind of do that yes and approach rather than like, nah, this supplement's stupid, throw it away. Because I think the yes and is really helpful. Like, hey, you're here, you're worried about your memory. Like, what are you eating? Are you getting a balanced diet? Do you have access to fruits, vegetables, nuts, and seafood? And what else can we be doing to take care of your brain? For example, blood pressure. Maybe this patient had high blood pressure. This patient, a different patient, has 141 over 90. So this is a 65-year-old woman with osteoporosis, a couple of falls, but pretty remote, and they sounded mechanical, tripping over rugs and such. But she's a little bit hypertensive in clinic, and she says, I don't really want to take meds, and I'm so glad I have a geriatrician because you don't try to push meds on me. But she says, some study I read in the New York Daily Mirror or whatever, linked, I'm trying not to I'm trying to make up a newspaper, but that might actually be one. Some study she heard linked blood pressure and dementia. Is that true? I mean, I don't really want to take meds, but what do you think, doctor? Should I treat this blood pressure? So this is the SPRINT study. Many of you may have heard about the SPRINT study. So you'll see a theme here. The memory was kind of attacked on as not necessarily an afterthought, but in these big studies, memory was only a part of a big study. So SPRINT study was a study to look at intensive versus kind of routine blood pressure control in older adults. So to get into the study, you had to be greater than 50 years of age. You had to have a systolic of greater than 130 and at least one other cardiovascular risk factor. And the goal is less than 120. They stopped the study early because it was working too well. And they said, this is unethical to continue it. So they stopped it early. And the SPRINT study helped inform the 2017 AHA-ACC guidelines. Now, as a part of SPRINT, there was SPRINT Mind. They had a bunch of outcomes looking at the brain, and almost everyone had a cognitive assessment. What the SPRINT Mind sub-study showed was that there was a significantly lower rate of incident MCI and a combined outcome of MCI plus dementia. Dementia alone was not significant, and they were wondering if it just they didn't have enough power to detect it. And then they got MRIs, which I love. They have all kinds of cool MRI results. So white matter hyperintensity volume increased in both groups, but less so in the treatment group. And I'll show you on the next slide a picture of that. They also did all kinds of fancy MRI imaging. So the group that got more intensive blood pressure control had improvements in diffuse and tensor imaging, myelination markers, and cerebral blood flow. So all these different mechanisms of brain health improved more or worsened less in the intensive group. And other studies have shown similar. Infinity, Preserve, Progress, Accord, Mind have shown reduction of white matter lesions. And limitations, this SPRINT Mind was a post hoc study, but this is a graph just showing the effect size of the smaller mean increases in white matter hyperintensity volume. So you're not necessarily getting rid of it, it's not going away, but you're having less white matter hyperintensities in these areas if you treat their blood pressure more aggressively. So for your lady who doesn't want to take meds, you're like, well, let's treat. And what would you put her on? This is where I'm at, where I'm at meetings. I'm like, yeah. We should treat their blood pressure. Get to your slide 8 or 9 or 10. What should we be putting them on? There's some, and so that's the thing we should start paying attention to next, not if we should treat. I think we're beyond that. Um, there's some data that angiotensin receptor blockers, and I think they mean dihydropyridine calcium channel blockers, might have better AD prevention above and beyond hypertension lowering. Post hoc claim, beware. But when I counsel my patients to ask their primary care doctor for med, I push the ARBs. And that's based on some meta-analyses that show maybe a little bit that dot that is more on the edge there. So stay tuned. All right, so blood pressure is hypertension is one of the Lancet 2020 risk factors. Don't worry, I'm not going to talk about the 2020 12 modifiable risk factors with the S, because now there's 14. So this working group, this Lancet Standing Commission met again. Now there's 14 risk factors. And so what did they do? You notice there was 12. Now there's 14, and then they had rearranged the list. So let me walk you through what they did. So here's the S. They have early, mid, and late life risk factors. Midlife is 45 to 65, if you're wondering. Okay. Late life is over 65. So there, they defined it for us. We're done. We know now forever what midlife is, according to the Lancet. Okay. So what they added to the list was high LDL cholesterol and untreated vision loss. The other thing they did is they moved smoking, depression, and physical inactivity and diabetes to the midlife risk factors. And they did not yet add sleep and diet. So don't at me. Yes, they know they're looking at data, but they didn't have strong enough data to add sleep apnea or sleep problems. My guess is that'll be in the Lancet 2028. So stay tuned. These are the risk factors. So I'm going to go to this table. So these are all epidemiologists and people who do this for a living. They calculate population attributable fractions. So they get big cohort studies and they calculate the relative risk, the prevalence, and then the weighted PAF. And then they add it all together. And they say the overall PAF for all risk factors is 45%. I think this is tricky because these are interrelated. If you have diabetes, you probably also have hypertension and high LDL, but they did their best to try to sort these all out individually. So early life, so kids, we're talking kids. Less education is associated with Alzheimer's risk. Relative risk 1.6, prevalence worldwide. I think this is worldwide. Yeah. Weighted PAF 5. Hearing loss, kind of a tiny relative risk, but it's so prevalent that it has a higher weighted PAF. So there's the relative risk times the prevalence that gets you your weighted. So you can have a tiny relative risk, but if it's really prevalent, it's contributing to more problems. Or if you have a big relative risk, but it's not as prevalent, it's contributing less. So I kind of like this table. So you can kind of stare at it for a while and kind of just think about, like, if in your community, what's the biggest problem? If you have a younger old population that's dealing more with like depression and smoking and diabetes, you want to put your emphasis there. Or if you have an older population, then you want to put your emphasis maybe on hearing loss and some other things. So I really like this table because you can kind of stare at it and think about what can you do in your community. Maybe if you live in Montana where it's nice, the air is clean, whatever. Maybe you don't care as much about air pollution. I mean, I'm sure they have some. Missoula definitely has some. Okay, but this is the big, so early, less education, midlife, we're talking hearing loss, high LDL, depression, TBI, physical inactivity, smoking, diabetes, hypertension, obesity, excessive alcohol consumption, which they define in the paper. And then late life, social isolation, which is above 65, social isolation, air pollution, and untreated vision loss. So when I was thinking about these risk factors, I wanted to think about like each of these risk factors is impacting the brain in a different way. And so I kind of put this framework together, very simplistic framework, which is, well, what are they doing? So here you have aging. So, aging itself is a thing that can also impact memory. So you have multiple mechanisms here: metabolism, senescence, telomere shortening, and things like that. You have you can, and so if you want to impact aging itself, the processes of aging, you can work on these things, which will also impact the mind. You can try to be resistant to these things. So if you don't get hypertension or don't smoke, then you won't get some of these neuropath diseases. So being resistant to some of these things by preventing them in the first place. There's also this phenomenon called resilience. So what that is you do have these things happen to you anyway, but you're resilient. So things like early education, exercise may be here as well. Your brain is protected from kind of the slings and arrows of life because you have more synapses, you've built more protection against pollution, for example, because you have more synapses to prune. So there's aging, resilience. So things like air pollution might cause accelerated aging and neuropath directly. TBI, we think, causes neuropath, and then if you're preventing things like social things, probably causes resilience. I don't know a mechanism of how it would, impact tau and whatnot, but it probably builds synapses. Social activities, education, things like that. And then I was reading the Lancet paper, and they have a thing like this too. There's just a lot more arrows. So I think I was kind of onto something by trying to make a framework. Here's all the different risk factors, and what do they do? These things up here decrease vascular damage, which makes sense. Reducing diabetes, managed cholesterol, minimizing hypertension. All of these things decrease vascular damage to your brain. Whereas depression, physical inactivity, alcohol, they kind of reduce damage, inflammation. And then what builds cognitive and brain reserve? Higher education, addressing hearing and visual loss, increasing social contact. So when you're thinking about those risk factors, like, well, how would that affect the brain? Well, this is how. And then they all interact in this section to prevent or delay dementia, either by preventing the damage in the first place or giving you resilience against it. Okay. Here's another patient you have in your clinic. You're seeing a 69-year-old man who is having an argument with his husband. This is almost a true story. Your patient claims that the crossword puzzle he does every day in the paper is best for keeping his brain sharp. But his husband says, no, 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 no. The fancy, expensive game his nephew gave him on his iPhone is much better. They want you to settle it. Okay. So this was a crossword puzzle study done by a colleague of mine. They did a study, 107 participants with mild cognitive impairment, 78 weeks of Lumosity, so kind of a fancy iPad game situation, or crossword puzzles on an iPad. They were both on an iPad. Okay. They did 12 weeks training plus 6 booster sessions, and the results were very interesting. The ADAS-Cog score worsened slightly for the Lumosity games, but improved for crosswords. And same with the functional activities, but the crossword group had less hippocampal atrophy over time than the Lumosity. So this was an interesting pilot study. The crossword puzzles was supposed to be kind of like a control group, but because of these results, we're now studying crossword puzzles low and high dose, and Lumosity is just not a part of the study anymore. So this was the data. So the crossword puzzle is here. This is looking at change from baseline. I think this was, ADAS-Cog, the primary outcome. And then the games are here. So that's so I guess to get back to your I guess I get back to the patient at the end. Okay, so let's take a step back for a minute. I talked about cognitive resilience and how these different things can help. Early educational attainment, as defined by the Lancet, and I think defined by people that have known this for years and years and years. Early educational attainment, we're talking kiddos in school. And then work complexity. So getting up and giving this talk, not hitting snooze and coming into work. Work complexity, these things definitely seem to prevent dementia, and they're additive effects. This is a great study that looked at four groups. So compared to low education and low work complexity. And if you want to go look at the study, I think, oh, I don't know if I have it referenced here. Oh, it's referenced in the Lancet Standing Commission. They have a pretty complicated way of defining high and low work complexity, but they have these four groups. People with low education and high complexity at work, the hazard ratio is 0.8. High education and low complexity at work, hazard ratio for getting dementia was 0.73. And then if you have both high education and high complexity at work, so many people on this call, hazard ratio 0.63. So that like going to school forever and working a high complexity job builds those synapses, builds that resilience. Now, you cannot recreate that by playing Pinochle starting in age 65. I wish you could. But I think, brain games at midlife. First, if you do all these things and you want to maintain that after you retire, I think that's something that's important. You have to retire. Sometimes you're forced to because you have memory loss. It's better than nothing. So I think continuing, if you have that, educational level and you're reading and whatnot, absolutely maintaining some type of stimulation for social and cognitive is crucial. And I think it's just important for our spiritual health, right? Like just, reading and, being around other people. We're social creatures. So, those kind of things are helpful. But do these cognitive trainings cover the breadth of cognitive function? Are they intensive, engaging enough? Are they delivered early enough in life? So no one's saying that, doing crossword puzzles is going to mimic going to law school and arguing in court for 20 years. Like nothing was going to replace that. And you can't go back in time if you have a patient that did not do these things. But, if you have a patient who, wants to start doing or wants to continue doing cognitive stimulation, I think we have enough data to show that it can at least stave off some pathology. And so what works, based on the best evidence that we have, and this will continue to be built as we do studies like the crossword puzzle study, do a mix of activities that challenge memory, language, spatial reasoning. So I think the reason Lumosity and some of these things work, they're not social, they're not, they're kind of just, they get repetitive. You want to balance difficulty with avoiding frustration. So you want to do something that you'll stick to. So crossword puzzles, I think, is a good one because if you like them, and you'll do them every day. People that do their crosswords every day, and they, stimulates memory and history, and you're looking stuff up in the dictionary and stuff. Find activities that are both mental and physical, like tennis, or mental and social, like again, D&D, or a language or a book club. For those people who didn't grow up in the 80s and roll dice. Activities done as a group or with a partner. Set aside an hour a day for your mind. Read, write letters, socialize. There's a lot of free brain games out there. And I think crosswords are probably better than Lumosity, at least according to one randomized controlled study. Okay, we're going to quickly talk about the pointer study, then we'll try to get to some of your questions. So the background for the pointer study, there was a landmark multi-domain intervention in Finland called the Finger Study, Finnish geriatric. It showed significant cognitive benefit after 2 years. So they took older adults at risk of Alzheimer's and cognitive decline, and they did like a multi-domain intervention, and it worked. So then they tried it in the US. So one of my previous mentors that used to be here, Dr. Laura Baker, was one of the PIs on this. Single blind multi-center RCT in 60 to 79-year-olds with risk factors for cognitive decline. For example, poor diet or lack of exercise. They had two arms, self-guided versus structured. And the demographics were pretty good, pretty representative of what the US is. 30% has no college degree. 30% from a racial and ethnic minority group. They really worked hard to make this more representative of a broad range of people from the United States. Big adherence. One of the things that wasn't adhered to is that brain HQ. So I think redundancy, because after 2 years, this thing gets super old. This is the intervention. So for the intense intervention, physical exercise, aerobic resistance and stretching and balance exercise, primarily to community facility like YMCA's with peer group meetings. So peers encouraging you to keep doing the things. Encouragement to follow the mind diet. Again, peer groups checking in. Cognitive and social challenges. So they got the Brain HQ and they were encouraged to keep playing it. And then health coaching. They got labs every 6 months. If your LDL was high, you were encouraged to talk with your doctor about getting on a statin, stuff like that. This is the data. Everyone got better. The structured group got even more better. This is a mean composite outcome change from baseline. This is a global composite Z-score comprised of executive function, episodic memory, and processing speed. Takeaways from the Pointer study are that the USA multi-domain intervention was successful. It had a high adherence rate and was safe. Both groups improved over time, but structural arm improved more. They felt that the greater structure, accountability, and intervention intensity produced a statistically significant relative enhancement in cognitive benefit. And the effect size was larger for those starting out with lower baseline cog function. That was a sensitivity analysis they reported at AAIC. What they also said at AAIC was this intervention caused the brain age to be 1 to 2 years younger on cognitive performance, an effect that could increase resilience against cognitive decline. Benefit was consistent across several key subgroups, including both males and females and people with and without the risk gene ApoE4. What can you do here? You can't enroll them in the Pointer study because it's over, but you can send them to the Memory Hub. This is a physical structure next to Harborview, close to Harborview, near the Frye Art Museum. It offers a wide range of in-person and virtual education support and wellness programs for people with memory loss and their families. And there's a garden that just won an award. If Genevieve's on the call, congratulations. You can also sign them up for the Dimensions newsletter. This is written by our wonderful science writer, Genevieve, and the link is here. You can sign them up in clinic, or that you can send savvy caregivers to the website. There's also a snail mail option. You can just email Genevieve on that website if they prefer like a copy. It's updates on research news. So for example, I write an article like this every 1 to 2 years, like how can you protect your brain? So they can get that. And then the other thing you can do is sign them up for the Alzheimer's Prevention Initiative. But I would encourage them to sign them up directly because this is a research registry. So when they hit send, they're actually agreeing to be a part of a registry that they might get recruited for. Whereas our Dimensions newsletter is just a newsletter. We won't sell that to any other like studies or anything. So in summary, there's always something you can do. For the worried well, or for those just starting to have memory loss, please discourage them from getting plasma biomarkers. And I guess if they have a positive result, you can talk to them about all these things. There's a lot of low-hanging fruit that you can discuss when patients bring in a supplement or the plasma A beta or whatever. This is very expensive and little data that works, but here's what you can do. I'm sure that someone has 14 risk factors. I have 2. I listen to loud music, so I'm at risk of hearing loss, and I don't exercise as much as I should. So those are 2 I can work on a daily basis. Cognitive activity, I probably have more than 2, honestly, but those are 2 I think about all the time, and it makes me angry that hearing loss is on there. Cognitive activities, making sure they're getting those. You could prescribe a multivitamin. Why not? I think there's data for that now. Sign them up for the newsletter if they want to get this, good information rather than like stuff on Facebook. If they already have cognitive decline, then I think it's a little bit of a different pathway. You do want to make a diagnosis, rule out delirium, rule out depression. If you do diagnose MCI or dementia, then you might want to refer, then you're talking about fancy testing and things. If they have, and then if they have moderate to late life dementia, I think this is a much different approach. I have some patients who are like headed towards like a nursing home and their families are trying to like follow the mind diet. And I'm like, give them ice cream. That's my recommendation. As much ice cream as they want. They have moderate to, heading into severe dementia. You're not going to impact their cognitive decline at this point. These interventions really work earlier rather than later. And then just as a point, preventing dementia is a public health issue. I talked to you about air pollution. I talked to you about keeping kiddos in school and, keeping spaces green, public parks and all that kind of stuff. Thank you so much. I love giving this talk because I hope it's just like a lot of positive energy, and we're probably all thinking right now, like, we all want to go on a walk, and although it's raining out. Um, uh, and hopefully I finished early enough. I am going to try to get through some questions. Um, Okay, I'm going to do the chat real quick and then we'll open it up. So, Kate Ritchie, magical thinking. Yes, that's why I love doing the D&D spell with the supplements. It cracked me up because there are a lot of D&D spells that have to do with mind and magic. So, Letitia James is going after Prevagen. So Prevagen is one of those, like, there's no data for it, like none. Like, and it's sold and it's like marketed by like famous actors that we know, and it's just, oh gosh, there's some political things I won't say. Okay. Do you know if they explore the types of education, like STEM, music, languages? That's such a great question. I don't know if they got into the details on that. Usually we just say how long. Like if you have a PhD in music, it's counted the same as a PhD in law. Computer addiction is prevalent. Data on cognition. That's a really, really interesting point, Dr. Plymate. Like, if you're on the computer and doing a lot of that stuff, maybe it's building certain synapses, but it's keeping you from like social. I think that should be studied as well. Sudoku, yeah. So I think there's this careful balance because if you're playing Sudoku or, there's a lot of different games that come out of like China and Japan that definitely help your brain. But if you're isolating yourself socially and only doing that and not, and sitting there and drinking Mountain Dew and whatever, that's not good for you. Pickleball, amazing. Um, the New York Times Games Pips is telling me I got to work on my spatial reasoning. I need to check that one out. It's interesting the head trauma in early life isn't on the risk factors. What is your understanding of this point? That is a good point. I don't know. I mean, head trauma is on the list of risk factors, but I think it just popped out as a risk factor in late life or in midlife because I think they're talking about sports. Like, well, but that would be early life. That is a really good point. I don't know. I don't study that so much. Psychosocial trauma, this is very difficult to study and make it's hard to measure. Like, what's your number? Yeah. Um, yeah, I mean, the 14 risk factors, right? There's just so much, even when you just take one risk factor, you could get into so much weeds. I'm going to stop sharing. If anyone needs that QR code again, let me know. I think it's also in the chat, just so I can see faces. Ah, there is a way to make the faces. How do I do that? Oh, meeting. There we go. Now I just need to make the grid. Zoom just keeps messing with me. Anybody have an audio question?
Sure, I do. I put it in the chat, but it's a great talk as always. You make it so informative and so much fun. It's just incredible. So I reviewed a paper and looked at some of the literature that's claiming vaccinations are useful, and the one I actually reviewed said that those who got flu and shingles vaccine had a 40% reduction in dementia. And just wondering what thoughts you might have about stuff like that.
Yeah, I saw that headline. I'm glad you brought that up because it's a reminder to go and read that paper and read about it. So I have to admit I haven't read the paper. But there is this huge body of literature that suggests that things like shingles, for example, or things like any of the herpes viruses that get into your brain can either cause or exacerbate neurodegenerative illnesses, right? And so if they're there, they're exacerbating. So I guess I don't have my slides, but the man, I wish I could see myself.
We can see your bottom.
It's fine. I know there's a way to make what Tom calls the Hollywood squares and see all the faces. I just can't get it to work on my computer today. Um, but uh, yeah, so I don't know if others that study this have more thoughts than me, but is it a matter of really preventing literally those infectious diseases that are not getting and exacerbating the inflammation caused by amyloid and tau, or is it really truly the case that these infections, quote unquote, cause dementia? You know what I mean?
Yeah,
Like,
I do.
'cause-
Yeah,
yeah,
I try to get into it. There's not a lot of literature in preventing bad pathogens. Yeah, is one I did. The other one was
yeah,
interesting though, that these stimulate the T helper cells, and that modulates neuroinflammation. So it's not. Oh, we can see you now. Yeah. Um, so it's not.
there.
And of course, these are not mutually